Hello. Welcome everyone to our last webinar of 2024. We can see that you're coming in. If you want to, you may use the chat function to let us know which country, city, or state you're joining us from. We are delighted to welcome you to our webinar today titled Interpreting Kidney Transplant from Jargon to Clarity. I am so excited. It promises to be a great webinar. Okay, as always, my name is Analia. I am the manager of training and curriculum here at Cross Cultural Communications, the leading U.S. training agency for medical and community interpreting and creators of Blue Horizon, our online learning platform for our self-paced and live training programs. I will be your host for today's 1-hour webinar. Also, with us today is my colleague, Andrew Hall, Cross-Cultural Communications Publications Manager. Andrew will manage the chat and will provide useful information throughout the webinar. Before we begin, and again, as we wait for everyone to come online, I would like to share a few pieces of training listed on our website for the spring of 2025. Can you believe it? 2025 is around the corner. Andrew will share the link of each training session as I mentioned them. Please remember, CC operates in the Eastern time zone. Okay, our first training coming up in February is titled Medical Terminology for Healthcare Interpreters. This 8-hour intensive workshop is a must-have for interpreters in healthcare settings. Led by the amazing Cindy Roth, you couldn't ask for a better opportunity to boost your skills in this area. The course also includes our medical terminology textbook at no additional charge. I tell you, we start 2025 giving goodies away. Okay, the next one is TCIITOT. The training of trainers trains and licenses interpreters to deliver the Community Interpreter International Program. This allows you to run your own training programs with the help and support of CCC. The spring cohort starts on March 17th through April the 4th. There will be 2 instructors, Carola Laymaker, and ta-da, yours truly, Analia Lang. Okay, now let's get busy with our webinar. I will go over a few things. The webinar presentation will last between 40 to 45 minutes, followed by a 15 to 20-minute Q&A period in which you can ask our presenter questions. During the webinar, please keep the Q&A feature open and use the Q&A to submit your questions to our presenter. For other questions for us here at Cross Cultural Communications, please use the chat feature instead. And if you want everyone to see your comments in the chat, please make sure your chat is set to everyone. Lastly, if you want to stay on after our presenter leaves at the end of the hour to chat with Andrew and me, we will be happy to answer your questions about both cross-cultural communications and Blue Horizon. Okay, now everyone, I know this is important because I am an interpreter myself, so please pay attention. This webinar has been approved for CE use. Please remember, 24 hours after the webinar, attendees will be emailed a link to download a certificate of attendance. It will go to the mail you used to register for this webinar. Please check your spam or junk folder if you don't see it. Certificates are only available for attendees of the live session of the webinar. Okay, another important piece of information to know. They must be downloaded within 3 weeks of today's session. Don't delay. We won't be able to send you a certificate after 3-week period. Also, after you download the certificate and you save it in your computer, you will want to add your name to the fillable field. Please add your name or it won't be accepted by the organization that you're submitting it to if they don't know, right? You can also print it if you choose to do so. Okay, now that everybody knows that, without further ado, let's begin our webinar titled Interpreter Kidney Transplant from Jargon to Clarity. Let's welcome our presenter, Gabriella Maldonado. Welcome,
Thank
Gabby.
you. What a
Oh,
presentation.
yes. Before Gabby takes over, let me tell you a little bit about my friend Gabriella. I call her Gabby. Gabby is a certified Spanish and Italian medical interpreter and currently serves as a quality assurance specialist at Cloudbreak Health. Gabriela holds a BA degree in bacteriology and a master's degree in human nutrition from and I'm going to say it in Spanish, Universidad Central de Venezuela and Universidad Simón Bolívar, respectively. Gabriela has also worked as a medical translator from English to Spanish and also as a Spanish medical editor for over 10 years. As a subject matter expert in interpreting quality, Gabriela has developed and delivered webinars, workshops, and training courses, and has presented at various conferences nationwide. We are truly honored to have Gabriela. Thank you, Gabby. I am going to disappear. The floor is yours. Have a wonderful time, and I'll see you when you're done.
Thank you, Analia. I will start sharing. Um, Thank you, everybody, for having me here, for coming to this webinar about interpreting kidney transplants. I created this webinar based on calls that I have monitored from our interpreters when they interpret kidney transplants, from my own interpretations, and also from documents that I have translated related to kidney transplants, clinical trials related to kidney transplants, and also letters, educational materials sent to patients who need kidney transplant. So these assignments are very long. They may last about 1 to 2 hours because the patient needs to meet with the transplant team, and also the patient's family will meet with the transplant team. I'd like to know in the chat if somebody has had experience interpreting kidney transplants. Okay, put it in the chat and I will continue with my presentation. Okay, it seems that some people. All right, so as I said, let me move this here. The transplant team is a multidisciplinary team. The team has different specialties, medical specialties, and they will do a comprehensive evaluation of the patient. So not every patient who has kidney failure is a good candidate to get a kidney transplant. The patient must be evaluated by this team. And why not everybody is suitable for a kidney transplant? It depends on many factors. For example, the age, if the patient has been on dialysis a lot of time, if the patient has diabetes, family support. So there are many factors that the team takes into consideration to determine if a patient is a good candidate to get a kidney transplant, right? So one of the members of this team is the transplant financial coordinator. A transplant financial coordinator will coordinate financial and insurance needs throughout the transplant process. In 2020, the cost of a kidney transplant was about $500,000. So it's a very expensive process. Of course, part of the team is the transplant surgeon. The transplant surgeon will evaluate the patient's medical condition, will make recommendations, and ultimately will perform the transplant surgery. There is also a transplant physician who is a nephrologist. The nephrologist also will help the surgeon evaluate the patient's needs of a transplant. Then we have a registered dietitian. A registered dietitian will develop nutrition therapy before and after transplant. It's very important for the candidate to have a healthy weight and an optimal nutrition status, because that will improve the transplant outcomes. Also, since these patients have kidney failure, their electrolytes in blood are unbalanced, because one of the main functions of the kidneys is to keep all electrolytes balanced in our blood. So because they have kidney failure, these electrolytes are unbalanced. So they need the help of the registered dietitian, because they need to follow a diet that will help to keep those electrolytes balanced. For example, if their sodium is too high, they need a low sodium diet. If you have interpreted for patients who are doing dialysis, I'm sure you heard that their phosphorus is very high. So the dietitian will recommend smaller portions of proteins, a smaller portion of nuts, beans, lentils. That's why a dietitian is very important for the team. I'm sure you interpreted a medicine called phosphorus binder, which is very common for patients under dialysis. So because they need medicines to keep those electrolytes in balance, as well as a good diet. All right. Okay. Another member is the transplant coordinator, who is usually a registered nurse. This transplant coordinator is the point of contact between the patient, their families, and the transplant team. They have also a social worker. A social worker will coordinate any help that the family and patient needs, any resources, and will also develop in a financial plan, and will do a psychological evaluation of the candidate too, which is very important. And also they will have a pharmacist. Keep in mind that these patients will need to take before transplant, during transplant, and after transplant, they will need to take a medicine that is called suppressant medicine that will keep their immune system calm, because otherwise that new kidney will be rejected. So the pharmacist will coordinate this transplant medication, will review current medication and see what medications can interact. So it's a very important member of the team. Very good. Continue. So also when you are interpreting, you are going to hear about these non-profit organizations for transplants. One is very common, UNIOS. UNIOS stands for United Network for Organ Sharing. UNIOS is the nation transplant system that manages the waiting list for transplant. They manage not only kidney transplant, they manage any organ transplant. They also are able to match donors to recipients 24/7, the whole year, every day of the year. They maintain the database of all organ transplants. Another organization is the OPTN that you may be interpreting. OPTN stands for, Organ Procurement and Transplant Network. It's a group of organizations is where the candidates are listed to wait for an organ. It's a public-private platform where all candidates are listed, and it's managed by unions. They also help to locate candidates who are the best match for a donor. No. Okay. Once the transplant team decides, okay, this patient is a good candidate for a kidney transplant, so let's put his name in this platform that I just mentioned, right? And they will be waiting for a kidney to be available. And I have some stats here that I considered very important. Over 80,000 people are waiting for a kidney transplant in the United States. Every 6 or 8 minutes, a person who needs a transplant is added to that list. Also, in 2023, more than 27,000 kidney transplants were performed in the United States. So it means that there are many thousand people still waiting for a kidney transplant to be available. And from those people waiting, about between 12 to 17 will die each day just waiting for a kidney to be available for them. Okay? So let's keep doing. There are two types of donors. We have a living donor who can be a family member, a good friend who is willing to give one of their kidneys. This is called a direct donation because the recipient or the candidate and the donor, they know each other, and that kidney will go, if it's a good match, to that recipient. But there is also non-direct donation, where somebody is a good Samaritan, wants to give one of their kidneys, and they say, please list my name. I'm able to give one of my kidneys to whoever needs it. Okay? And there is also called pair donation. Pair donation works this way. For example, here in Columbus, there is a candidate who has a family member who wants to give this candidate a kidney, but unfortunately, this kidney is not a good match for the candidate. But in Oklahoma, there is the same situation. There is a patient, a candidate who has a family member with a kidney, but the kidney is not a good match for this candidate. But this important platform, Unions, the one that I just named, will do the research, will look through the nation network and will say, okay, but this kidney in Oklahoma could be a good match for this person in Ohio, in Columbus, and this kidney in Columbus is a good match for this candidate in Oklahoma. It's something like this. Donor 1 is not a good match for the recipient 1. Donor 2 is not a good match for recipient 2. But donor 1 is a good match for 2, and donor 2 a good match for recipient 1. So they swap their kidneys. The other donor that we have is the deceased donor. When somebody died and it happened that this person was listed as a donor. Now, a deceased donor must die in the hospital. Why? Because it's the best environment to preserve that organ, that kidney in this case. That person will be connected to machines, organs will be connected to machines that are giving blood and oxygen to preserve that organ. Okay? So that's the other donor that we may have. All right. So before a kidney is available, for example, the person died, this person is a donor, so that the hospital called Unions and says, we have a kidney available. Somebody from the transplant team will, if they need to fly, they'll travel, they will go there with their cooler, the kidney is put in the cooler, and they drive back where the candidate is waiting. They will have about 24 to 36 hours. So, but anyway, when they have the kidney, they need to calculate this score that you are going to be interpreting to, which is KDPI. KDPI stands for Kidney Donor Profile Index. And it's an index that we let it's assigned to the donor, to that kidney, and we let unions know, this organization, the estimated lifetime that this kidney will be functioning in this new body, in this candidate, right? This KDPI is calculated based on the age of the donor, a lifestyle of the donor, if the donor had diabetes, because we know diabetes affect kidneys, if the donor had hypertension affects kidneys, if he had diabetes, all that. They calculate levels of creatinine, they find the medical history. Okay, what was the creatinine level of this patient? Because creatinine levels is a measure of kidney function. So they get all these factors and they calculate the KDPI. If you focus on this graph, just focus on the blue bars, we see that between 0 to 20%, that kidney may last about 12 years. Between 21 and 85, it may last 9. Between 86 to 100, about 6 years. So the lower the number, no, the higher, more years, the longer this kidney will be functioning in this candidate. Now, if you see living donors also, they get a KDPI, but with an L before K, because it stands for Living Kidney Donor Profile Index. And for living donor, the time for that kidney being functioning is about 12 years. Remember, this is an estimated time. It could be more, it could be less. But why? You are wondering why a kidney from a living donor will last more? It will last more because they perform the kidney transplant in the same operating room. They have the candidate here or recipient, they have the donor next to the recipient, they remove the kidney from the donor and they connected it to the candidate's or recipient body, and it should be start functioning immediately. Okay, but from this donor, this KDPI, it's a long process. So they need to inform the transplant team. They need to inform the transplant hospital. They need to travel. They need to put the kidney in the cooler. So that time is a time that it's a wasting time. So, and that time for that kidney waiting in there to be transplanted in the liver, in the body, in the candidate, will affect the lifetime for that kidney. Okay, that's why it's better to have a living donor. Okay, let's keep going. Another terminology that you are going to hear in this interpretation is called EPST. EPST stands for Estimated Post-Transplant Survival. EPST is a score but assigned to the recipient, to the patient waiting for that transplant. And it predicts how long a patient is likely to benefit from a kidney transplant. It also ranges from 0 to 100%. EPST will determine the candidate's position on that wait list. So patients with a lower EPST score will be higher on the list, on the top. Pediatric patients are given preferences. So young people will be on the top of that list. And that means that they will be called first when there is a kidney available. And how they calculate this EPST? They calculate it based on age of the recipient, length of time in dialysis, because remember, dialysis affects the body, so the longer they have been on dialysis, that affects the EPST, and that number will be higher. And if the number is higher, they will be lower in the list. If they have been diagnosed with diabetes, that will affect them will put them lower in the list. So lifestyle, so many other factors will affect that score and will determine the position of that candidate on that waiting list. Okay. Also, if they have had other transplants, those transplant work, that's another factor that they take into consideration. Very good. Okay, now we have our candidate, we have everything. However, they need to see if that kidney from that donor is a good match for that recipient. Okay, and the first test they need to do is kidney compatible blood typing. As you know, there are 4 types of blood type: group A, B, AB, and O. If a candidate is group A, it means that on the surface of their red cells, this is a red cells, they have these proteins called antigen A. They are called antigen A because they are able to trigger an immune response. And they will have in their plasma antibodies, anti-B, to protect their cells, okay? Same thing for group B. If the candidate group B will have antigens B and antibodies anti-A, the opposite. If a candidate is group AB, they will have both antigens and non-antibodies. Because if they have antibodies, those antibodies will destroy their own red cells. And group O won't have any antigens and therefore must have both anti-A and anti-B. So this is like when you get a blood transfusion, you need somebody compatible to your blood type. However, in a kidney transplant, a recipient is not, they won't get a blood transfusion unless there is an emergency. They are getting a kidney. So why this is important? This is important because that kidney has one artery and one vein. And through those blood vessels, this new kidney will be connected to the body of that recipient. And in those blood vessels, they will have also these antigens. So if the recipient is group A, they need to have a kidney from somebody who is group A or group O, because otherwise there's going to be rejection. Why group O? Because group O doesn't have any antigen, okay? If you are from group B, you need a donor from group B or group O. If you are AB, you are a lucky candidate, a lucky recipient, because you can get kidneys from any blood type, from A, B, AB, and O. And if you are from the group O, you need a donor, a kidney from a donor who is group O. So as you can see, group AB, candidates from the group AB are the universal recipient, and donors from group O are the universal donor, because they can donor their kidneys to anybody. Now, it means that a candidate and donor who don't have the same blood type or don't have a compatible blood type it won't work. They cannot have a kidney. Yes, they can. They can because there are medicines to immunosuppressive medicine to suppress these antibodies. Okay, these antibodies will be suppressed, and in that way, the immune system won't attack that kidney. However, it's still a risk, and the probability of having a kidney rejection due to blood type incompatibility is only 1%. So it's very low, but it's still a risk that is present. Okay, now we have our blood type. Don't get scary with this image, I will explain. This is what is going to happen if there is an incompatibility of blood type, just for you to understand better. We have a recipient that is blood type B. It means that it has antigen B and it has antibodies anti-A, right? Remember, you are blood type A, you have antibodies anti-A in your blood. And the donor has another blood type, type A. It means that the donor has antigens A in their blood vessels. The blood vessels that I told you that they used to connect the kidney, right? So inside the blood vessels of the donor, this in yellow, is the antigen A from the donor. As soon as the kidney is connected, the antibodies from the recipient, who are antibody anti-A, will get attached to this antigen. They will bind, and as soon as they bind, that trigger an immune reaction. Many cells from the immune system will come, platelets will come, blood clots will come, and they will destroy in minutes this kidney. And this is called an hyperacute transplant rejection. It's hyperacute because it occurs in minutes, and they need to remove the kidney immediately. Okay, that's what happens. Now, the other test that they need to do to figure out is if a donor is a good candidate. It's a good kidney for the candidate is the human leukocyte antigen typing, or HLA. HLA is a group of proteins, just like the blood type is a group of proteins, but instead of being on the top, on the surface of the red cells, they are on the surface of the white cells, or leukocyte, and on the surface of many cells in any tissues in our body. And they are very specific to each of us. So I have my HLI, you have your own HLI, okay? And we inherited them from our parents. So for example, here is represented. We have this mother's HLI type is this, and this father's HLI type is this. And when they have children, these are their children, they will have different combinations, right, of HLI. Now, for these kids, none of them have the same match, right? But if you look at the right, you see this little boy, he needs a kidney. He has this HLI combination. And fortunately, his sister has a full match. So she could be a good kidney donor for him. However, the other two siblings don't. Now, you see how it gets complicated, that matching, right? You need to find somebody like you. However, not everybody has 3 more siblings. Maybe none of the siblings are a good match, like these ones. So that's an important test that they need to perform before transplanting that kidney. Okay, now what happens? Well, you hear a lot about transplant rejection. So what happens in a transplant rejection? So here, these cells is present in the recipient. And these cells is called CD4 or T cells. They are very important in our immune system because they will alert of any intruder, any foreign body in our body. It could be a virus, it could be anything that is weird for them. So the recipient will have their own HLA because remember, HLA is our ID. And it may happen that they say, they are circulating, they say, oh, this HLA is different. And when they bind, that binding will alert the other cells from the immune system. It will alert the CD8 killer. They are cytotoxic and they will come and destroy that kidney. They will alert also the B cells. B cells will produce antibodies and will go and destroy the kidney also. And at the end, the kidney is destroyed, is rejected. And this is called an acute transplant rejection that may happen weeks or months after transplant. And you are now wondering, okay, but it was a HLA. The sister was a good match for the boy. But that is true. But even with that, it was a good match, but it wasn't exactly the same match. So even a slight difference in these proteins that form the HLI ID will trigger an immune response. That's why it's so important, and for you as interpreters to interpret accurately each medicine that the patient needs to take for the rest of their life, because those medicines will avoid this immune response. Okay? Even after years of transplant, rejection can occur after years, and it's called a chronic transplant rejection. And why this happens? Not only because there is a slight difference in HLA, it may happen after pregnancy. Sometimes when you are pregnant, you can develop antibodies that may irritate this immune system. You can get a blood transfusion that may irritate. You can get a viral infection. So you can get many other things that irritate your immune system and waking up the immune system and destroy the transplanted kidney, right? Now, I talked about the blood typing. I explained the HLA testing or tissue typing, right? The last one test is the cross-match or cross-matching. So what is cross-matching? Is the other test that they must do before to find compatibility between donor and recipient. What is this? So it's a lab test. They do it in a lab, they draw the blood from the recipient, and they obtain the serum from that blood, and they will combine the serum from the recipient with the donor's lymphocyte. Remember, these lymphocytes are white cells that have on the surface this famous HLA, remember? And they also will add complement. Complement are proteins that participate in the immune response. So they put everything together, and what they are trying to do, they are trying to see if the recipient has preformed antibodies that may attack the kidney. So we have two results, negative or positive. If it's negative, it means that the recipient doesn't have any antibody that will bind to the HLA from the donor cells, and therefore there is a good chance that the kidney won't be rejected. But if it's positive, it means that the recipient has antibodies that are binding with the donor lymphocyte or HLA, and that cell, those white cells will we destroy, uh, and it's the same phenomenon that will occur when the kidney is transplanted. The kidney will be destroyed too. Why this person has this antibody, nobody knows exactly the reason. Maybe because he was exposed to other viruses, and it may happen that antibody affected, got binded with the donor, so nobody knows. But it's a test that must be done before a kidney transplant. Analia, I like to know, because I cannot see, who has experience in interpreting kidney translations before I continue. Kidney interpretation, I'm sorry. Kidney transplants.
Can people answer in the chat again? Because I think it was a while ago. Let's see. Has anybody interpreted in kidney transplant surgery? Say, oh, okay, several people are saying, yes, I do. I have interpreted. I did. Okay, so you do have several people, Gabby. So you
Okay,
can go on. Very good.
very
Thank you,
good.
everybody.
I'm happy. I'm happy for that. Okay, thank you, Analia. Okay, very good. Now, this is an example of a simplified OPTN list entry. Remember, OPTN is the platform where candidates will be listed, right? So on the left, we have this patient's name, John Doe, blood type A positive. So it means that he will need a donor who is A positive or a donor O positive. Remember, O positive is the universal donor. And organ needed a kidney. Remember, in this platform, they have any donor, any candidate, and any donor. It could be kidney, it could be hearts, lungs, everything. Also, they will have a medical urgency level if it's high, for example, due to the advanced kidney disease. If this is a pediatric patient, will be listed as a urgency level. So remember all the factors that I told you that will determine the position on the list. Also, the waiting list, this patient, John, is on the position 15th, meaning that they are currently 15th in line for a suitable kidney based on their medical criteria. And remember that part of that medical criteria is the EPST, to see how healthy is this candidate to get this kidney, okay? And the location is very important. That's why it's so important also when you are interpreting that the patient, you interpret very accurately patient's phone number. Phone numbers are very important to contact the patient. They will use it to call them and say, hey, there is a kidney here present. So be careful when interpreting phone numbers, contact information, address, emergency contact. All of that is crucial to contact the patient, because if they don't find the candidate, they will go on the list down to the other one, to the other candidate, okay? Now, on the right, you will see donor ID number. They try to keep confidential the donor's name. In this case, they assign an ID number, 1234. KDPI, remember the score to see for how long this kidney will live. In this case, is 35%, so it's kind of high. Blood type A positive, that's good because it matches the candidate's blood type. Age 50A, middle age. Cause of death, trauma. Okay, remember, the deceased donor must die from something that will preserve their organs. Also, if they have cancer, it will be difficult to get a healthy organ, right? Serum creatinine levels are very important, 1.2, normal range, it's good. He didn't have any kidney failure. History of diabetes, no, that's a good sign. History of hypertension, yes, but it's controlled, okay? So they try to match recipient with a donor. All right. Now, we are almost finalizing. What we take from this? First, organ transplantation is considered one of the miracles of modern medicines. 50 years ago, it looked like almost impossible, but it's a miracle that we can take an organ from this donor and put it in this candidate and starts functioning, and we save his life. That's beautiful, right? That's a miracle. Also, keep in mind that one single donor can save up to 8 human lives, meaning that a deceased donor can give 2 lungs, can give 2 kidneys, can give a liver, even skin, can give many of their organs if they are suitable to save 8 lives, 8 human lives. There are many challenges, as I just showed you, because first, there isn't enough donors. And even if you are a donor, remember that you have to die. I'm sorry I'm saying this, but you have to die in the hospital, right? And your organs should be preserved. So maybe it's a car accident and you damage your kidneys, that kidney is not be able to be donored, okay? So you have to preserve your organs. Also, we saw the challenges with rejection. Rejection can happen even years after transplantation. So these patients need to have this regimen of medicines. They need to take these medicines always. They may take between 5 to 15 different medicines, immunosuppressant medicines, to keep that kidney in their bodies. So when you interpret medicines, please pay attention on the names, ask for spelling, ask for clarifications, how the patient needs to take this medication, the frequency, the dosage, milligrams, everything because it's super important. We saw all the ABO typing, blood typing that may happen too. So it's still a challenging to get that kidney in this candidate's body. Now, what the future holds? Well, what is interesting is that I was hearing a conference about this doctor who had more than 25 years in organ transplant. He said that, of course, when the donor died in the operating room or in the room where he's connected, ICU, wherever he is, these organs are connected to a machine that is giving them, supplying oxygen to keep them alive until somebody from the kidney transplant comes to take this kidney, right? Or any other organ. However, once this person comes, they need to take out from this body this kidney. And the body is given to their families, right? But with a machine perfusion, these organs can be connected to this machine perfusion and could travel where the patient is connected to this machine perfusion. This machine will keep giving oxygen, nutrients to these organs. Like it's like transporting the body with all the organs connected, okay? So all organs will be functioning and the machine will keep these organs outside the human body in a good shape. Some hospital transplant are using machine perfusion, but not all of them, because of cost, because of complexity, because of clinical needs. There are still questions about when perfusion is more appropriate to use. So it's still under surveillance, okay? This this doctor also said that in the next year, researchers will be able to convert any blood type to O type. Remember, type O or blood type group O is the universal donor. So researchers are doing researching to be able to convert. For example, the donor has a different blood type. So remembering the blood vessels of that kidney will have these antigens from the blood. Well, they are trying to have these antigens converted to O type. So to avoid any ABO or blood type incompatibility. Also, in the next 10 to 20 years, researchers will be able to change the donor genetic makeup, the famous HLA. Okay, so they are trying to have the same HLA in the recipient. The donor will have the same HLA that the recipient has to avoid any organ rejection. All right, so that's the end of this presentation. Thank you so much for having me, and I'm open to any questions. If I'm able to answer any questions, I will more than happy. If not, I can find the answer, okay?
Gabby, amazing, amazing presentation. Maybe for sure, so much, everybody's just sharing how informative, how educational, how interesting. Thank you so much.
Do you
Okay,
want me to stop sharing
yes,
or?
yes. Go
Okay.
ahead. You can go ahead and stop sharing, and we'll start with the questions. Okay, here's one question. Hi, one of my companies that I work with asked me to have E and M insurance. As an interpreter contractor, I would like to ask about emissions and omissions insurance. Okay, so I guess this is not
Yeah,
related to the
I
topic.
can answer that one. Yeah. No, I can't.
Okay, so people will get to that one later. Okay, very interesting question. Let's go to, okay, here. How is the life expectancy of the kidney determined? Does it use the actuarial tables used by the life insurance companies as a basis?
I don't understand the question, to be honest. With insurance
Yes, it says, okay, so the question is about the life expectancy,
of
right?
the
And then it,
organ. Mm-hmm.
of the kidney. Then it says,
Mm-hmm.
does it use the actuarial tables used by the life insurance companies as a basis? So it
Oh,
seems to
mm-hmm.
me like, do you know if they need take into consideration what the insurance will consider the expectancy of the kidney?
Oh, I don't know about how insurance gets involved, but I assume it will get involved because they need to have a financial plan. They need to find
Yes.
insurance and coverage. Yes, maybe their insurance have their own rules. And the life expectancy of the kidney is what I explained. Remember with the two scores, KDPI and the one from the candidate. Mhm.
Okay, thank you, Gabby. Okay, have you interpreted for a patient having a transplant due to lupus nephritis? And in such cases, how involved is the rheumatologist with the team?
Oh, okay. No, I haven't, but yes, since they have an immune disorder, maybe that could be a factor that
Hmm.
affect their eligibility to get a kidney transplant. I would assume that, but so every patient is a unique case. So that's why they have a transplant team, and they will decide if this patient is a good candidate for a kidney transplant.
Gabby, I am going to interject my own question because I think for people like me that have not interpreted for a kidney transplant, I would there is so much information. Again, everybody's going to the recording is going to be posted on our website by the end of the day tomorrow. I will have to re-listen to this presentation. So much great information. Um, just quickly, if people will have to take a takeaway from this presentation, could you give us one takeaway, like what they should really ensure that they know? What
Okay.
would you suggest?
So, as interpreter, and keep in mind, now that you know, you have an idea of this complex process. So, when you get an interpretation for a kidney transplant, keep in mind first medications. Okay, I have to be
Hmm.
accurate interpreting medication. I have to be accurate interpreting contact information, um, even your ethical part. So, because you will see, I remember one interpretation when the patient was so happy because he had a family member who wanted to give her kidney, and the social worker said, I'm happy you have somebody, but you have to go through all this process, and maybe she's not a good candidate. And I was, oh
Mm,
my. And she was traveling from another country to the United States, and you had to look his face change.
mm,
So keep in mind that you're going to be dealing with this. So you have to
mhm,
be unbiased. You have to keep you calm. Maybe this is not a good candidate, or maybe this is not a good donor. Maybe they are rendering the test. I'm sorry, your HLA test for your donor is not compatible with you. And they may say, but she's my sister.
mm.
I'm sorry, but and then they start to explain all the process that I explained. Wise.
Wow.
So those three things, yeah, three things.
Just a lot. Okay, here's another question. The person says, very informative webinar. Thank you so very much, Gabriella and CCC. And here's the question. Could you say a few words about consent forms? I interpret in stem cell transplant settings, and I have noticed that consent forms are never translated into French. I interpret from French-speaking patients. I wonder if the situation is different for Spanish. Thank you.
Oh, unfortunately, yeah, yeah, it's different. In Spanish, yeah, every document must be translated for clinical trials. Maybe it is because of the amount of people, Spanish-speaking peoples in the country, that is mandatory. Sometimes that happens that when the language, maybe there are not many French people living here, I assume maybe that's one of the issues, that it maybe it's not mandatory, but you can lead, you can say, hey, let's have this translated into French. They should, right? For the patient.
Somebody's saying I have side translated 100 forms in Spanish.
Yeah,
Hmm.
Spanish is mandatory.
Yes. Okay. Well, thank you. We have several more questions. Let's see. Okay. Does the life expectancy of the kidney also differ if the donor and or recipient is a child?
Yes, age is a key factor.
Mm,
But as I said, every patient is unique. So I can say, in pediatric patient will last more, because there are many other factors that may influence in that lifetime. So it depends, and that's why they have a team, a transplant team, and they have even a committee. The committee will gather all the information from the donor and from
mm.
the candidate and will decide. There are many factors that affect that kidney or the patient. Yes.
Wow. Okay. Let's see what else. Oh, so I guess there was a discrepancy in some of the slides. It said the slide showed EPST and EPTS. Which expression is correct?
I'm sorry, my mistake. We have EPSC and the other one was
EPTS.
EPTS. No, EPST.
EPST. Okay, so the
No,
correct
sorry, EPST from survival. Thank you
E,
for that. I will make sure to correct it.
okay, so EPST. Okay.
EPTS.
Okay, so the correct is EPTS.
Okay.
Okay.
Mhm.
Okay, would there be a Spanish?
Survival time. I'm so sorry. EPST. That's why. EPST.
Okay, the correct
Estimate
one is PST. Okay.
survival time.
Okay.
Thank you.
You're welcome. There will be a Spanish vocabulary list for the most common terminology used in during the kidney transplants. I guess it sounds like they're asking if you're providing a list.
I don't have it. I should create it. Okay. But if I create, I will send it to you, Analia. If I have time, more than happy to do it.
Okay, thank you so much, Gabby. Okay, another one. What is the role of the translator during a transplant? So we're assuming this is the role of the interpreter. Do you know of any incidents where the interpretation errors, example, made the situation worse, or where the interpreter contribution helped prevent medical mistakes?
Well, personally, I haven't witnessed anything that where the interpreter prevented something, or an interpreter's error affected the outcome. No, but it's a risk. It's a risk, and
Mhm.
that's why we, as interpreter, we need to intervene immediately. We realize that we said something wrong, or we didn't understand something, or we need to intervene because among the speakers there is something that was not understood, or was an error. So any situation is different. That's why you need to be alert as interpreter. Mhm.
Yes, if we do carry a huge responsibility in our interpretation. And
Yes,
the ethical thing to do is that, hey, we made a mistake, we just correct it. That's the ethical
exactly.
thing to do.
Yeah, and as I said, contact information is very important. Phone numbers,
Mhm.
write them down and be careful and confirm them, because it's amazing how one wrong number in a phone number is devastating because they will call somebody else. Okay,
Exactly.
so that's very important.
I think a good rule would be just to always repeat back what we wrote down, right? Where is the phone number, the address, the name of the person that we need to reach out to. That way we ensure that we didn't transpose, the number of the
Yes,
information.
exactly. And I just remembered the letters that I have translated. And
Mm-hmm.
I remember this letter say, we have been trying to contact you by phone. We have not been able to contact you. This letter is to inform you that you have been removed from the list until you contact
Oh,
us. You see? Horrible.
wow.
Hmm.
Yes. And people wait for a kidney um, for years. Sometimes they die waiting for a kidney.
Yeah, for about 5, 10 years, and it depends
Yes.
on your blood type, you know.
Yeah,
Hmm.
so we do carry a tremendous responsibility to ensure that our interpretation is correct, is complete, is better to ask over and over and over if we need to. Okay, here's a different type of question. Any holistic approach to kidney disease?
So instead of a transplant.
Well, they said disease, but you have been interpreting about transplant. So
Hmm.
either take, Gabby, anything that you can give us
Yeah,
any
because there are
insight.
other, yeah, when the patient is not a good candidate for a kidney transplant, they are offered other options, dialysis.
Mm.
Um, um, there is this procedure to remove toxins from the blood with dialysis, hemodialysis, peritoneal dialysis, or other options. Yeah.
And everybody, I'll just take a second. Is the 12:31, so the webinar is formally over. If you need to go back to work or to your lunch or to the next commitment, please be sure that we are going to send you your certificate of attendance. Gabby graciously is going to stay with us maybe another 5 minutes at the most, but I did wanted to stop for a second and thank everyone for your wonderful contribution and to support to CCC, because we do this because of wonderful people like Gabby, a wonderful interpreter and trainer and QA specialist that is donated from her time and life just to share with us her knowledge. I mean, this is just amazing. So anyway, for those that need to leave, feel free to leave. Let's gonna ask you one more question or two, Gabby. The next one is there a difference in meaning or interpretation between blood type and group?
No, there is no difference. So they say there are different blood types, right? And
Mhm.
they are group those blood type in group A, group B, group C, group I'm sorry, group A, B, group O. Not really. It's like the way they say it in English. Yeah.
Okay, so blood
Mhm.
type and blood group is the same, right?
Yeah.
Okay,
Hmm.
perfect, awesome, simple. And we like it that. Okay,
So group A will have everybody type A. Group B, everybody type B. That's what I meant. Hmm.
okay. Once a kidney is destroyed due to hyperacute transplant rejection, is this organ useful for any other recipient?
No, no, because that reaction is super aggressive. The immune reaction, the immune
Mm,
response will destroy the kidney. It's not function anymore. Yeah.
wow. Carmen Grock from Indianapolis
I
says,
saw
thank you
her
for the
name.
presentation. We
Hi,
know her,
Carmen.
people. We
Yeah.
know her because we used to work together. Okay, let's see. Do you know why surgeons don't remove the old kidney? I'm not sure
That's
what
a
that.
good question. They keep their kidney. I think because, I know why. I think I
Okay.
read it. I think because they still anatomically, it's good to have it. Because I think they remove it, they will have that space. So I think it's better to have it. And kidneys still are functioning even a little bit. And that
Uh-huh.
would help. But I need to find the real question. I think I read something like that. I'm sure a nephrologist will answer better than me.
Oh,
Mhm.
oh, this is
It
interesting
is
question for
interesting,
sure.
yeah. Mhm.
Okay. Let's see. Let's see. Okay, I want to ask if all the rules and regulations that are applied to the donors are the same elsewhere.
Here in the States, yes.
Mm-hmm.
Mhm.
Well,
And probably um, in other countries, so the rules about matching, those are
mm-hmm.
universal because that's the test that they need to the testing. I don't know if in others, the listing, the way they are listing listed. Maybe it's different in other countries. I don't know. But the rule to find a match, yes, those are universal because those are mandatory. It's the only
Yes.
way. Yeah,
Otherwise, they will be killing people by trying to save them.
exactly.
Wouldn't that be awful?
Yeah.
Okay, last question, Gabby. You've been so gracious to stay with us. What is the best system you have seen a patient adopt or a hospital develop for a patient to keep track of medicines, to have the best chance that everything will be taken, nothing missed?
hmm So in the hospital, what they do with the pharmacist is a process that they call reconciliation, where
Hmm.
the pharmacist comes because the patient getting the transplant, right, is in the hospital, and the pharmacist comes and starts one by one. Okay, you are taking this medicine, you have to stop this. You are gonna take this medicine, this is the name of the medicine, this is how you will take it. Repeat after me. What are you gonna take now? What
Hmm.
you need to stop? Is a process, and the interpreter is key in that process, because you have to interpret everything accurately. And
Yes.
that just that process of reconciliation will take about an hour, may take. And the pharmacist is so patient because the
Hmm.
pharmacist knows how important this is, and will repeat for you, will spell it again. Is They are super nice because they know how important this will be for the patient.
Wow. Thank you, Gabby. Well, Gabby, we are going to let you go. I know you got to go back to your own job, but thank you so much for sharing your time, your
Pleasure.
expertise, your knowledge with us, with the profession. Everybody has been so excited about the information you have shared. I had never heard anything about kidney transplant. I have learned a lot, but I'll be honest, I'll have to
So,
rewatch it and take notes because this was just fascinating. A lot
thank
of
you.
great information, Gabby. Thank you so much.
No, thank you for having me. Thank you, everybody. Happy holidays, and see you next one. Okay.
Okay, see you next, Gabby.
Bye.
Bye.
Thank you. Bye.
Thank you.